So in the talk that I gave at ASHA with Tova Fian, we talked a lot about patient autonomy. And one of the questions that came up at the very end was, how do you support a patient's autonomy when trying to complete oral care? If they are just like, absolutely not, they hate it, they don't like it. And I love that question because this is where nuance comes in. So when we are making decisions clinically, when we're making recommendations, we need to do it from a risk to benefit standpoint and analysis. And when we are using that risk to benefit analysis, we're considering what the evidence says, we're considering what we think clinically, and then also those family values, right? So like, that is how we get to informed consent. Basically, we have all three pieces and we present that information. I think that when we're looking at something like oral care, this is where there's a lot of benefits that come from supporting oral care, right? Like dental health, gum health, preventing from some long-term diseases because of dental issues, dental decay. Not to mention the fact that if we have pharyngeal dysphagia, this may also be reducing the risk of infections. And so there is a lot of benefit that comes to it. Now, when we're looking at the risk side here, we're thinking about, okay, is this potentially going to influence oral aversion? Is it going to play a role in how that impacts the child eating orally, drinking orally? Like, where does that play into it? When we look at the risk to benefit of doing oral care versus not doing oral care, the benefits significantly outweigh the risks. And there's just too many risks involved. Now, that doesn't mean we don't try to support patient autonomy during that process and try to encourage it. We collaborate with our OTs. We try to provide different strategies, use distractions, like anything we can to reduce the negative piece that some patients may experience with oral care, but we can't just not do it. I would compare this similarly to a patient who requires medications for seizures, or some kiddos that, you know, have EOE that have to get the Dupixent shot. That is, a lot of people report it's fairly painful, but the risk to benefit, right? It's a have to. It's a have to. And there's certain times that we have to do it versus taking the risks of what happens if we don't do it. Again, want to work on supporting the patient autonomy and that process throughout it as much as possible. And that's really what that's about, is like figuring out those just right pieces. And then also recognizing that sometimes we have to make the really difficult decision of saying, we have to do this, even if the patient doesn't fully understand the why behind it. And that's hard. That's really, really hard. But I also want to bring this up because this is the same type of approach we should be taking when we see clinicians that are, you know, considering some more alternative, less evidence-based types of interventions. You know, things that come into my head is low light laser therapy, neuromuscular electrical stimulation, using things like that, the risk to benefit analysis. These are things that we do not have the evidence to show of any benefit. And while we may see low risk, there's never no risk. We also don't know what it does long term. And with certain ones, there's higher risks than others. And so if we don't have the benefits that are really outweighing the risks involved, we shouldn't be making decisions. We shouldn't be making those types of recommendations. I hope that helps. Let me know what you think in the comments. This is a really, really hard conversation, and it's difficult to navigate the pros, the cons, the risk to benefit, really getting informed consent and supporting patient autonomy in some of these situations. So let me know what you think. And if you have any types of strategies or things that have been beneficial to you or your patients, or even your kids on oral care and supporting them through that, please drop them below because I know families will appreciate it.